hypertensive disorders in pregnancy, any topic, any discussion, any case starts with the patient particulars. So what are the patient details that you need to focus on when it's hypertensive disorder? Now, you know that there are certain risk factors. Whenever you're covering any disease, every disease has certain risk factors. For example, if I tell you that it is a case of FGM or IUGM, what are the risk factors? The risk factors would be, say, a teenage pregnancy, or a late elderly pregnancy, or a multi-pregnancy, or undernutrition. So when it's a patient detail, you need to ask these questions. You need to ask, you have to look at certain points, focus on certain points, so that you go to the risk factors of that disease. For example, if it's a hypertensive disorder in pregnancy, we know that age is important because teenagers and advanced maternal age both are at very high risk of preeclampsia, eclampsia, gestation hypertension, etc. Right? Teenagers are more commonly associated with preeclampsia, whereas advanced maternal age will be more commonly associated with chronic hypertension. But both of these cases, there would be hypertension, and that will be deleterious for the pregnancy. So age is extremely important. What else would be important? The parity, because we know that preemie gravidas and hence teenage pregnancies are at a higher risk of preeclampsia, because for the first time there is exposure of the father's genes to the mother. So because of that, there could be a problem with the trophoblastic invasion, which can lead to preeclampsia, right? So parity, age, all of these are extremely important when you're taking history of preeclampsia. In patient details, what next? You have to focus on the symptoms. So अगर आपके पास एक preeclampsia का patient आ रहा है, you know that this patient has a BP of 140/90. What are the symptoms that you would expect in such a patient? That what are the symptoms that you will specifically ask? Now, sometimes what happens is you go retrograde. You take the history. The patient gives in the exam. The patient will give you a symptom like, I just came for a routine checkup and they admitted me. I don't know why. Maybe they do not know why. Or maybe she'd give an example like, I had slight abdominal pain, right? But now I don't have abdominal. And you would be wondering कि abdominal pain का question या abdominal pain का case थोड़ी ना हो सकता है. इसको होगा क्या? And then when you measure the BP, you find out that the BP is 140/90, and you understand that this is a patient of preeclampsia. As soon as you get to know that the BP is 140/90, the patient is preeclampsia, then what will you do? You will go back and revisit your symptoms. And then in the symptoms, you will again ask these questions. That is there swelling on the feet? And if there is swelling on the feet, कब आया? Onset. कितने टाइम से है? Duration. और क्या वो पहले टो पे था, फिर एंकल पे आया, फिर शिन तक आया? Is it progressing or is it stationary? And is it relieved by rest or not? Why are these things important? Because you need to differentiate between the physiological edema of pregnancy and the pathological edema of preeclampsia. So swelling of feet is extremely important symptom in preeclampsia. Second is swelling of face, abdominal wall, vulva, or generalized swelling. That is anasaka. ये क्यों पूछना है? Why do we have to ask these things? Because it denotes the extent of preeclampsia. If it is just 140/90 BP and swelling of the feet, ठीक है, simple preeclampsia. Shin भी involve हो रहा है, vulva involve हो रहा है, abdominal wall edema हो रहा है. All of this may show you that there is increased proteinuria, right? There is extreme loss of protein, right? And that might indicate that it may be a long-standing preeclampsia or a severe preeclampsia. But note that proteinuria amount is not related to preeclampsia. That one thing you need to know, okay? That it does not indicate severity. However, the extent of symptoms on the patient will definitely tell you for how long the preeclampsia has been lasting in this patient. Third, the very important imminent signs of impending eclampsia: headache, blurring of vision, photophobia, epigastric pain, right upper quadrant pain. That is all symptoms of imminent eclampsia, right? Whenever there is edema, cerebral edema, the patient will give complaints of headache and blurring of vision. When there is edema of the liver, but the liver is expanding but not being able to cross the Gleason's capsule, because of which there is pain in the right upper quadrant, then that indicates what? imminent eclampsia. Decreased urine output. If the patient is telling you that there is decreased urination, then that again indicates that the patient might be going towards some kind of a renal component failure, which might also be a case of severe preeclampsia. And lastly, if she is already diagnosed with preeclampsia, sometimes patient might just come to you and say like that, I'm diagnosed, I'm taking labetalol, 100 milligram 2 times a day. She'll tell you all of this, right? Then you need to ascertain this thing, that when did we start you on this medication? Why? Because if the labetalol is started at say 16 weeks of gestation, then more likely it is a chronic hypertension. If it is being started at say 24, 25, 26 weeks of gestation, then it is more likely to be a gestational or a preeclampsia rather than a chronic hypertension. So you need to ascertain whether it is chronic hypertension or it is preeclampsia. So this is the first table you need to understand, the difference between physiological edema and pathological edema, right? The timing. As I said, that first symptom that we have discussed, the swelling of the feet, this edema. You have to talk about this edema. You have to find out what is causing this edema, right? So is it physiological? If it is developing only in the third trimester, it would be physiological. But pathological will develop when the patient develops preeclampsia. That means it can develop during any time in pregnancy. Then physiological edema would be dependent edema. That means physiological edema does not extend the legs, whereas pathological edema would be in the non-dependent areas also. It is never physiological to find edema on the face, on the abdominal wall, in the vulva. It is never true. It is never physiological. It is always pathological. Then response to rest. Of course, physiological edema subsides on rest, whereas pathological edema does not subside even after rest. And lastly, blood pressure, not associated with blood pressure, whereas pathological edema is associated with blood pressure. If you cross these many questions, the next question the examiner will ask you for the patient is this: what are the histories that you have taken to rule out other causes? Is there a history of chronic hypertension? That is history of increased blood pressure before 20 weeks? Yes, then it is chronic hypertension. No, then it might be preeclampsia. Is there a history of chest pain, breathlessness, orthopnea, or palpitations? Why? What if it's a cardiac condition which is leading to increased blood pressure? What if it's a cardiac condition associated with preeclampsia? Or what if it's a preeclampsia which has led to cardiac condition? It could be anything. Preeclampsia leading to cardiac condition, preeclampsia being associated with cardiac condition, or a cardiac condition leading to preeclampsia. In all of these cases, you have to rule out a cardiac disease. So history of chest pain, breathlessness, orthopnea, palpitation, this is a must. If you can say this, you will definitely get those brownie points. No history of seizures in the past. Why? What if this patient has been admitted because she had an episode of seizure and her BP was 140/90, and you immediately diagnose कि तो eclampsia ही है. This is eclampsia, so sure shot eclampsia. And when you do not take this history, and she does not reveal to you that maybe in the childhood also she had an episode of seizure, you have missed a diagnosis of epilepsy, and you have labeled the person as eclampsia. A patient who has epilepsy, you treat her with magnesium sulfate, she will not respond. Her treatment should be done with anti-epileptic drugs like levetiracetam, right, which are conducive to pregnancy. So therefore, very important history, that there is no history of seizures prior to pregnancy, because you have to rule out any epileptic disorder. Then, is there a history of decreased urine output? Because you have to rule out renal component. Is there a renal disorder? Again, like cardiac disorders, preeclampsia could coexist with the renal disorder. Preeclampsia could be because of a renal disorder, and renal disorders can lead to preeclampsia. Okay, so any of these things can happen. If there is a history of antepartum hemorrhage, why? What if it's a 30-week patient who has been admitted because of bleeding per vagina? Usually, they will not give you a case of abruptio placenta in the ward, but of course, you need to take into consideration that if there is bleeding along with preeclampsia, along with hypertension, increased blood pressure, what is it? It is most likely to be a abruptio-placenta, right? So that is what you have to keep in mind. Then they will ask you, what is the differential diagnosis? Now, on the basis of this much history and a BP of 140 by 90 or above, you should be able to give what is the diagnosis of this hypertensive disorder, whether it is gestational hypertension, or it is a chronic hypertension, or it is preeclampsia without severe features, or it is preeclampsia with severe features. What is the differential diagnosis? Or it could be preeclampsia superimposed on chronic hypertension. So then once you give these differential diagnoses, the next question that you will be asked is, very surely you'll be asked is, how do you differentiate? What is your method to differentially diagnose it? How will you diagnose it?